Thank you so much. That's really kind of you, Dr. Chitra. And thank you again very much for having me on this very important program. So can I see the video, please? And before I start, I'm going to be showing a case of coloboma. Can you pause the video, please? So as we are aware, the coloboma, Phaco and a coloboma case could be a little more complex right from the capsular Rhexis, because the capsular Rhexis chance of it running away is high with the inferior zonular loss and the chance of fibrosis in the inferior aspect. Can we play the video, please? So we take good precaution. I use a soft shell technique, use a dispersive and a viscoelastic. The Rhexis is complete here. You can see my Rhexis was fine. However, after hydro, this is a grade 4 cataract. As I was starting Phaco, I realized my Rhexis was torn. So probably with the hydro, my Rhexis had given away. So I'm doing Phaco. I'm being very careful. A chop technique is being done. My rotation also is very gentle, but I find that the nucleus is kind of tilting. It doesn't seem stable at this stage. So I want to confirm if the nucleus is fine. So I'm just trying to move it around, and I see the equator of the nucleus, which indicates that the inferior capsular support is inadequate. So as I'm trying to prolapse it out of the bag, it tends to dislocate posteriorly. So I'm rescuing it with the help of the Sinski, which I'm using. Other hand, I have another instrument, another Sinski. So I try to sandwich this nucleus out between both these instruments into the anterior chamber. Again, this is a very hard cataract, so I would not want to extend this existing 2.2 millimeter corneal wound. So this is where our SIC skills would be useful. So I abandon the corneal incision, make a superior 7 millimeter sclera corneal tunnel. So this is, the nucleus is safe because it is in the anterior chamber. There is iris to support it. The wound can be as large as you would like it. I use a vectors here. It's a regular vectors. I just try to avoid hydration. So I try to avoid the enlargement of the capsule tear. And then the viscoelastic is used to remove the cortex. In this case, the IOL was placed in the sulcus and iris fixated. So I'm just going to show you a second case of a similar kind, but again, this is an Intumescent cataract, used a high molecular weight viscoelastic. I'm being very careful here, used a forceps, tried to make the Rhexis much smaller inferiorly, but there, as you can see, there is some fibrosis in the capsule, and it kind of runs out right there. So and again, it's very Intumescent, and I know it's going to be almost impossible to bring this back. So in this case, I don't wait to continue with Phaco because I'm sure that this is going to have a high chance of lens matter dislocation. So earlier in the case, I convert, go superior, do a scleral tunnel. Like I said, most 99% things would work fine, but sometimes when we do have a Rhexis tear in such a situation where there's a high chance of dislocation, it's good to convert. So I'm again using two instruments, bimanual prolapse, bringing the nucleus out into the anterior chamber. It's a soft cataract, and that is useful. So the wound would match the nucleus size. I'm placing a 3-piece PMMA IOL in the sulcus. I'm placing the IOL horizontally. So both the haptics have support. However, since the capsular support is inadequate inferiorly, I would like to fixate the haptics to the iris. Using a 10-O Prolin suture on a long curved needle, taking a bite from the cornea, go through the iris and take a bite, including the haptic, and come out through the cornea. And then through the incision here, since it's just above the bite, I would tie the knots. So here I would, knowing the position of the haptics, I would take this bite. It's a little blind procedure, but since you know where the haptics lie, you can be almost sure to include it. And you could also confirm, after you have taken the bite, you could lift both the ends of the suture to see if the IOL tilts, which is an indication that the suture has included the haptic. Both the haptics are secured to the iris on either side. I leave the bag in place because the chance of contraction is low. It's a coloboma case. Again, we'll have to manage these patients post-op as well because there's a high chance of raised intraocular pressure, etc.
That was a lovely video, Haripriya. So the questions related to the iris fixation I would ask in your second video because there was a lot more to it there. So here we see a beautiful case where in a lenticular coloboma you expect some zonular instability and she deals with it SICS. And the second case, it's an Intumescent cataract and she's got a Rhexis extension. She's not going to take chances and she's done an SICS again. Now the question for you here is that if you had had an intact Rhexis? First of all, maybe if you had created a Rhexis well away from the area of the coloboma and a smaller Rhexis to start with, probably that would help, would it? The second question is,
I think so. Yeah.
And
Please
the
go
second
ahead.
question is, if you have an intact Rhexis in these eyes with the lenticular coloboma, doesn't it make sense that we could put a CTR in these eyes, which probably would even prevent fluid misdirection through that area of zonular weakness? Your thoughts on that?
Yeah. So regarding the aspect of making the Rhexis smaller, I think that's a very valid point, especially the first case. My Rhexis was slightly larger on the inferior side. If I had made it a little smaller, that could have reduced the chance of that Rhexis extension, which happened during hydro. The second case, however, I was being very careful, but considering some of these eyes have, when you see those the fibrotic plaque on the anterior capsule, need to be very, very careful. Those are the cases where the chance of extension is much higher. Regarding using hooks or CTR, CTR, so either of this, I would normally delay or avoid it as much as I can, especially hooks. The only case I do not use hooks routinely in a case of lens subluxation would be a coloboma, because like I said, what seems like a normal Rhexis may give during pressure, during phaco in a colobomatous eye. Same with the CTR as well. So I would delay the implantation of CTR. I would place it as early as it is required, but delay it as much as I can so that there is no issue with this kind of compromising the strength of the capsular Rhexis and causing an extension. Now, all this is doesn't happen in every colobomatous case, but the risk is more than having it in other cases of subluxation.
Yeah, that was
Dr. Haripriya.
Yes, Dr. Harsh.
Do you like to do pupilloplasty at the end of the surgery in iris coloboma
I
cases?
used to many years back, but now I see that patients are absolutely asymptomatic, so they don't really have, because they've been used to this all their lives. If it is a traumatic case, then I would, then they have issue of glare and halos, etc. But I think coloboma patients have never complained, so I would spare them and more manipulation could increase chance of IOP and inflammation, so I would not do it now.
Kumar, you have a question for us?
We can't
Kumar,
hear you.
Unmute, Dr.
Unmute
Kumar.
yourself, Kumar.
Yeah, sorry. If you have a small Rhexis in the area of the coloboma, the opacification of the backside of the Rhexis itself will prevent the extra light from coming in. So you really don't need to do any, as rightly mentioned by Dr. Haripriya, that you don't really need to do pupilloplasty, because what I prefer is that we make a little smaller Rhexis in the area of the coloboma and don't polish off the posterior capsule, the cells on the posterior surface of the anterior capsule. Over 3 weeks, they become opaque, and that itself filters off the extra light.
I think I would like to make one comment here.
Yes, sure.
But I would like to congratulate Dr. Haripriya for demonstrating a very important philosophy. That is, whatever we do has to be in the best interest of the patient, and that takes precedence over the surgeon's ego. Now, you could have really continued with phacoemulsification and landed up in more problems, but then she showed a beautiful management, and the eventual outcome of the patient, I think, would have been wonderful. So, thank you so much for conveying this take-home message for the viewers.
Thank you, sir.